Chronic suppurative otitis media. So we will be discussing the types of CSOM, etiology, pathology, features, investigation, and treatment. So first of all, chronic suppurative otitis media is a long-standing infection of a part or whole of the medullary cleft, which is characterized by ear discharge and a permanent perforation. This is a picture showing purulent discharge and a perforation in the tympanic membrane. This shows the normal tympanic membrane. Types of CSOM. First is tubotympanic, also called as safe or benign type. It involves anteroinferior part of medullary cleft, that is eustachian tube and mesotympanum. It is associated with a central perforation and there is no risk of serious complications. Second is anticoantral, which is also called as unsafe or dangerous type. It involves the posterior superior part of the cleft, that is the attic, antrum, and the mastoid. It is associated with an attic or a marginal perforation. The disease is often associated with a bone eroding process such as cholesteatoma or presence of granulations or osteitis. In this type, the risk of complications is high. Um, this is the eustachian tube. This is the part which is involved in the safe type of CSM, while this portion, the attic, adductus, antrum, the mastoid air cell system, these areas, that is the posterior superior part, this is involved in the antecoantral disease or the dangerous type, while this portion, the anteroinferior part, is involved in the safe type or the tubotympanic type of CSM. The differences between tubotympanic and antecoantral type of CSOM. The difference is in the characteristic of the discharge. In case of tubotympanic or safe type, the discharge is profuse, mucoid, and odorless, while in case of antecoantral or unsafe type, the discharge is scanty, purulent, and foul-smelling. There is difference in the perforation. The perforation in tubotympanic or safe type is central, while the perforation in case of antecoantral or unsafe type is attic or marginal. The presence of granulations and cholesteatoma is common in antecoantral or unsafe type. Polyp, if present in safe, is pale, while it is red fleshy in case of antecoantral. The risk of complications is common in unsafe type, and audiogram shows mild to moderate conductive hearing loss in case of tubotympanic, while it shows conductive or mixed hearing loss in case of unsafe type. This is a picture of the tympanic membrane in case of a tubotympanic disease where there is a perforation in the anteroinferior part of the tympanic membrane. This is a central perforation. The etiology is the disease starts usually in childhood. It is a sequel of acute otitis media. The perforation is central and it becomes permanent with margins epithelialized, and it permits repeated infections from the external ear. There can be ascending infections to the eustachian tube, that is, infections from the tonsils, adenoids, or sinuses, which may be responsible for persistent or recurring otorrhea. Persistent mucoid otorrhea is sometimes the result of allergy to certain ingestions such as milk, egg, fish, etc. The pathology: there is perforation of the pars tensa. Second, the middle ear mucosa is edematous and velvety when the disease is active. Then polyp, it is usually pale, contrast to uh, big fleshy polyp which is seen in aticoantral disease. Then the ossicular chain is usually intact and mobile, but may show some degree of necrosis, particularly the long process of incus. Tympanosclerosis, it is seen as white chalky deposits on the promontory or ossicles, joints, tendons, oval or round window, and this interferes with the mobility of these structures and cause conductive deafness. And lastly, fibrosis and adhesions. Bacteriology: the pus culture in both the types of aerobic and anaerobic uh, bacteria. The common aerobic organisms are Pseudomonas aeruginosa, Proteus, E. coli, Staph aureus. The anaerobes include Bacteroides fragilis or anaerobic streptococci. So chronic otitis media is divided into mucosal disease or squamosal disease. The mucosal disease is either active, inactive, or healed. Squamosal disease is either active or inactive, which could be in the form of retraction pockets. The stages: active stage is where at the time of examination the ear is discharging. Recent stage where there is no discharge at present, but in the recent past the discharge was present. Inactive stage where the ear is dry for the last 3 to 6 months, and healed stage where the tympanic membrane perforation has healed. Uh, Basically, the middle ear infection is permanently controlled. Clinical features: first, the patient presents with ear discharge, which is non-foul smelling, mucoid or mucopurulent, uh, continuous or intermittent. Hearing loss: patient presents with hearing loss, which is conductive type of hearing loss, which rarely exceeds 50 decibel of hearing loss. Uh, on examination, there is perforation, which is always central, and through the perforation, the middle ear mucosa can be visible. Investigations. To confirm the findings, examination under microscope is done. Uh, then the first, if the disease is active, the first is sent for culture and sensitivity. Pure tone audiogram to assess for the type of hearing loss and the degree of hearing loss. X-ray of the mastoid area. Treatment uh, in case of active disease, oral toilet. Second is topical ear drops. The antibiotic ear drops containing neomycin, polymyxin B, chloromycetin, or gentamicin are used, combined with steroids, which have got local anti-inflammatory effect. Systemic antibiotics, water precautions. The patient is asked to keep the ear dry. Treatment of any other causes, and this is followed by surgical treatment, reconstructive surgery. In case of aticoantral disease, this involves the posterior superior aspect of the middle ear cleft. This is associated with cholesteatoma, which has got bone eroding properties. It's also called as unsafe or dangerous type. Etiology is same. Uh, this is particularly seen in case of sclerotic mastoid. The pathology includes cholesteatoma, granulation tissue osteitis, vascular necrosis, cholesterol granuloma. These are few pictures of the tympanic membrane, and this shows the attic cholesteatoma. This shows the involvement of the attic region along with a small central perforation in the pars tensa. Etiology is same as in case of tubotympanic disease. The symptoms: patient presents with ear discharge, which is scanty, purulent, always foul smelling due to the bony involvement. The patient also presents with decreased hearing, uh, but there is a condition which is called as cholesteatoma hearer, in which, in presence of cholesteatoma, where the ossicles have been destroyed, the cholesteatoma bridges the gap which is caused by the destroyed ossicles, and that leads to continuation of the conductive pathway of the sound, and so the hearing is almost normal even in presence of destroyed ossicles. So these individuals are known as cholesteatoma hearers. The patient also complains of blood discharge from the ear that can occur due to granulations or a polyp. On examination, uh, there is a perforation which is either attic or marginal. A retraction pocket may be seen. Uh, that is basically an invagination of the tympanic membrane in the area of attic or posterior superior part of the pars tensa. Then presence of cholesteatoma. These are the stages of uh, retraction. Stage 1 is tympanic membrane is retracted but does not touch the incus. Stage 2, where the tympanic membrane is retracted and touches the incus, 3 is also called as middle ear atelectasis, where the tympanic membrane comes to lie on the promontory and ossicles, so that the middle ear space is obliterated partially or totally. Stage 4 is also called as adhesive otitis media, where the tympanic membrane drapes over the promontory and the ossicles. The tympanic membrane gets adhered to the promontory. The investigation, examination under microscope is done to confirm the findings and also uh, the extent of the disease. Tunic-Cope test, Pureton audiogram to assess the degree of hearing loss and the uh, type of hearing loss. X-ray of the mastoid region, CT scan of the temporal bone. So, the hearing loss in case of unsafe CSOM can be purely conductive or a mixed hearing loss. Now, on a CT scan, uh, first thing is this disease occurs in poorly pneumatized mastoid. An important finding which helps to differentiate in between the two types of CSOM is the presence of bony erosion, which is present in the unsafe CSOM. Erosion of lateral wall of the epitympanum and of the ossicular chain is common in cholesteatoma around 75% of times. Erosion can occur in chronic otitis media, but less than 10% of case. This is a CT scan picture of a 54-year-old male with normal pneumatized mastoid area, well aerated mastoid air cells. While this is a CT scan picture uh, of the mastoid, which is completely sclerotic, no air cells are present. This is the CT scan picture of a 14-year-old boy with the eardrum, which is thickened. A small amount of soft tissue is visible between the scutum and the ossicular chain. Then this is a picture of CT scan showing tympanosclerosis. Tympanosclerosis, this is the eardrum, the tympanic membrane, which shows tympanosclerosis. Uh, what are the different symptoms, sign and symptoms, if the patient is developing complications in case of CSOM? First, pain. Second, vertigo. Persistent headache. Facial weakness. Listless child refusing to take feeds and easily going to sleep in case of extradural abscess. Fever, nausea, vomiting in case of any intracranial infection. Neck rigidity, irritability in case of meningitis. Diplopia in case of Grady-Negro syndrome. Ataxia in case of cerebellar abscess or labyrinthitis. and abscess around the ear in case of mastoiditis. Treatment is surgical, in which there is reconstructive surgery and conservative treatment. The canal wall up surgery indicates the posterior canal wall which is remain intact. Uh, this is a picture where the mastoid drilling has been done from the McEwen's triangle, exposing the areas, the synovial angle, the horizontal bulge of horizontal semicircular canal or the lateral semicircular canal seen in the floor of the mastoid cavity. Sigmoid sinus, area of the sigmoid sinus. This is the mastoid tip. Then the root of the zygoma. This is the tegmen plate. The advantages and disadvantages of canal wall up and canal wall down procedures in case of CSOM. The advantages of canal wall up, uh, physiological position of the tympanic membrane. There is enough middle ear space and no mastoid cavity problem. The disadvantage is residual and recurrent cholesteatoma may occur. There can be incomplete exteriorization of facial recess, and second stage operation is often required. In wall down procedure, the advantages are residual cholesteatoma easily found on follow-up evaluation. Recurrent cholesteatoma is rare, and there is total exteriorization of the facial recess. There is a disadvantage of mastoid cavity problem. Middle ear is shallow and it's difficult to reconstruct. The cholesteatoma. These are few pictures. In the first one, there is a perforation in the attic area, which shows cholesteatoma flakes. In the second, again, there is the involvement of the attic area. In the third, there is polyp coming out from the attic area. And in the last picture, there is presence of hemorrhagic polyp from the attic area. Uh, Normally, the middle ear cleft is lined by different types of epithelium in different areas, such as the attic receives the pavement kind of epithelium. The mesotympanum and the hypotympanum has got the respiratory epithelium, that is the pseudostratified ciliated columnar epithelium. But it is the presence of keratinizing squamous epithelium in the middle ear or the mastoid, that is skin in the wrong place, which is termed as cholesteatoma. So it has got two parts, the matrix and a central white mass, also known as epidermosis or keratoma. The matrix is made up of keratinizing squamous epithelium resting on a thin stroma of fibrous tissue, and central white mass consists of keratin debris produced by the matrix. There are different theories for the origin of the cholesteatoma. First is presence of congenital cell rest. Second is Whitmark's theory, that is invagination of the tympanic membrane in the region of posterior superior part of pars tensa or the attic, which leads to formation of retraction pockets. Then Rudy's theory, which suggests the basal cell hyperplasia, which is responsible for the formation of cholesteatoma. Haberman's theory, which suggests epithelial invasion through a pre-perforation of the tympanic membrane. And last is the Sadie's theory, which suggests metaplastic changes in the medullary mucosa. Classification of cholesteatoma. It is classified into congenital, acquired, that is primary acquired, secondary acquired. Congenital cholesteatoma, it arises from embryonic epidermal cell rest. The three common sites of congenital cholesteatoma is the medullary, petrous apex, and at the cerebellopontine angle. It presents as a white mass behind an intact tympanic membrane and causes conductive hearing loss. It may be sometimes discovered on routine examination of children or at the time of myringotomy. Primary acquired cholesteatoma. There is no history of previous otitis media or any pre-existing perforation. So the theories which suggest the genesis of primary acquired cholesteatoma are invagination of the pars flaccida, basal cell hyperplasia, or squamous metaplasia. Secondary acquired cholesteatoma, there is already a pre-existing perforation. This is often associated with posterior superior marginal perforation. The theories on its genesis are migration of the squamous epithelium or keratinizing squamous metaplasia. How there occurs the expansion of cholesteatoma and destruction of bone. It invades the surrounding structures through the path of least resistance and then the enzymatic bone destruction. Now, the attic cholesteatoma may extend backwards into the aditus and antrum mastoid air cells, downwards into the mesotympanum. Medially, it may surround the incus or the head of malleus, cause destruction of the ear ossicles. It can cause erosion of the bony labyrinth, can cause erosion of the facial nerve canal, or the sinus plate or tegmen tympani may be involved. The various enzymes such as collagenase, acid phosphatase, proteolytic enzymes are also involved in the enzymatic bone destruction procedure. So, eustachian tube obstruction leads to persistent negative pressure in the middle ear, which leads to retraction pocket formation in the attic or the posterior superior part of the pars tensor, leading to formation of primary acquired cholesteatoma by either proliferation of the basal layers or metaplasia of the middle ear mucosa. Secondary acquired cholesteatoma occurs as a result of repeated infections through pre-perforation of the tympanic membrane, or metaplasia of the middle ear mucosa. Acute necrotizing otitis media leading to large central or marginal perforation and epithelial migration through the perforation can also lead to secondary acquired cholesteatoma. The complications of middle ear disease, the factors which influence the development of complications, age, poor socioeconomic groups, uh, overcrowding, poor health education, poor personal hygiene, limited access to healthcare. These play an important part. Third is if the organism is highly virulent, if the host is immunocompromised, then through the preformed pathways, the infection can easily travel beyond the middle ear cleft if preformed pathways exist. The pathways of spread of infection could be through direct bone erosion, venous thrombophlebitis, or some preformed pathways which can be congenital dehiscence, that is in the facial canal, floor of the middle ear over the region of jugular bulb, presence of patent sutures like petrosquamous suture, previous skull fractures. The fracture sites heal only by the fibrous scar, which can permit infection. Surgical defects, as in case of stapedectomy, fenestration, or mastoidectomy with exposure of the dura. Oval or round windows. Infection from the labyrinth can travel along the internal acoustic meatus, aqueduct of the vestibule, and that of the cochlea to the meninges. The uh, complications are classified as intratemporal, that is within the confines of the temporal bones, and intracranial. The intratemporal complications include mastoiditis, most common, patrositis, facial paralysis, labyrinthitis, while intracranial complications include extradural abscess, subdural abscess, meningitis, brain abscess, lateral sinus thrombophlebitis, otitis hydrocephalus. Sequel of otitis media, uh, perforation of the tympanic membrane, ossicular erosion, atelectasis, atelectasis, adhesive otitis media, tympanosclerosis, cholesteatoma formation, conductive hearing loss due to ossicular erosion or fixation, sensorineural hearing loss, speech impairment, learning disabilities.